Welcome to Bookfulness. This is episode 37 in our deep dive series using clinically oriented anatomy. We're aiming to, translate this dense text into knowledge you can actually use in a clinical setting.
Yeah, last time we really got into the weeds with the nose and the ear, didn't we?
Oh.
Covered things like Tourette, barotrauma, Meniere's disease,
Yeah.
really highlighted how tiny structural details impact function hugely.
Definitely. So today we're sort of zooming out. The source material gives us this interesting mix, connecting the big bony structures that anchor us, like the lower limb, with the mechanics of how we move, and then jumping all the way up to the skull, the protective case for the brain and its pathways.
Right, so our mission really is to pull out the key clinical insights from the sections on the lower limb and the cranium. We'll be looking at things like biomechanics, important spots for surgical access, and, how vulnerable some of those cranial nerves can be.
Which is, let's face it, foundational stuff. If you're going to understand movement problems, deal with trauma, or get your head around neuroanatomy.
Absolutely essential.
Okay, let's start right at the base then. The pelvic girdle. This is really the anchor point, isn't it? Connecting the spine to the legs. What's the first thing students need to lock down about the hip bone structure?
I think the main thing is understanding it's made of three fused bones. They all meet at the acetabulum. That's the deep socket for the femur head. You've got the ilium sitting superiorly.
That's the biggest part.
Yeah, the largest part. Then the ischium is postero-inferior, sort of behind and below. And the pubis is anteromedial front and towards the middle. Each one carries a significant functional load and has its own clinical relevance.
And talking about the ilium, you immediately think of the iliac crest. It just feels like the top edge of your hip bone, but the book calls it a protective bumper.
It really is. It's the biggest bony surface you can easily feel just under the skin. It's a massive attachment site for layers of abdominal and back muscles. Their aponeuroses anchor there. And that crest ends at the front at a really key point, the anterior superior iliac spine. Yeah. The ACIS. Honestly, you can't overstate its importance as a landmark. For measuring leg length, finding the midpoint of the inguinal ligament, planning surgeries, it's your go-to spot.
Okay, so ilium is about anchorage and muscle attachments. What about the ischium? It sounds like its main job is dealing with weight.
Precisely. That rough bit at the bottom, the ischial tuberosity, that's literally what you're sitting on. It bears your body weight when seated. But it's also, critically, where your hamstrings, the posterior thigh muscles, attach proximally.
And that connection is important clinically.
Hugely, especially in, say, adolescent athletes, think sprinters, hurdlers. That sudden, powerful hamstring contraction can actually pull a piece of the ischial tuberosity clean off. It's an avulsion fracture. The tendon is stronger than the bone attachment point at that age.
Ouch. Okay, that segues nicely into the femur itself, longest bone, strongest bone. But the geometry, especially where the neck meets the shaft, seems quite specific. Can you talk about that angle of inclination?
Sure. So the angle between the femoral neck and the shaft is normally around, say, 125 degrees in an adult. This angle basically sets up the whole mechanical line of the femur. And if it deviates, well, you get significant biomechanical problems.
How so? What happens if it deviates?
Well, if the angle decreases, gets smaller than 125 degrees, we call that coxavara. If it increases, it's coxavalda.
And why is that distinction important for, someone studying this?
Because it has direct, visible effects. Coxavara, for instance, usually causes a bit of limb shortening. But importantly, it limits how far you can passively abduct the hip, move a leg out sideways. So if you see a patient who can't easily move their leg away from the midline, you should be thinking about this angle.
Okay, that makes sense.
But maybe the most critical thing linked to this, especially in kids or teens, is a condition called a dislocated epiphysis of the femoral head.
The growth plate slips.
Exactly. The top part of the femur, the epiphysis, slips relative to the neck. And as it does, it tends to force the angle into more and more coxavara. The really tricky part clinically is the pain often shows up in the knee, not the hip.
Referred pain again.
Classic diagnostic trap. You have to consider the hip even if the patient points to their knee.
Good point. Okay, before we get into how we actually move, let's quickly touch on the fibula. Slender bone sits posterolateral to the tibia. The book's pretty clear it plays no role in bearing weight. So if it's not holding us up, why is it even there?
Well, it's got two main jobs. First, it's an important site for muscle attachments. Second, and maybe more critically, it's vital for ankle stability. It forms that lateral part of the ankle mortise and is key to the tibiofibular syndesmosis.
That strong fibrous joint holding the tibia and fibula together at the ankle.
Exactly. That syndesmosis is what keeps the ankle stable. And anatomically, notice the lateral malleolus, the bump on the outside of your ankle formed by the fibula, hangs lower and sits slightly more posterior than the medial malleolus on the tibia. That helps explain why ankle sprains usually happen when you roll your foot inwards, an inversion sprain.
Makes sense. And its clinical use, I remember reading something about surgery.
Ah, yes. This is a really high yield point for surgery. Because the fibula isn't essential for weight bearing, surgeons often use sections of it for bone grafting.
Like take a piece out and put it somewhere else.
Precisely. You can harvest a piece, sometimes even with its own artery and vein, of vascularized graft, and use it to rebuild, say, a jawbone after cancer surgery, or fix a gap in another long bone. When doing that vascularized transfer, finding the fibula's nutrient foramen, usually in the middle third, is absolutely critical.
Why is that?
Because you have to preserve that blood supply. If the graft doesn't have blood flow, it won't survive. The fibula is kind of the body's built-in spare part for bone reconstruction.
Fascinating. Okay, so we have the bony foundation. Let's talk about how we use it the gait cycle. Understanding how we walk seems pretty fundamental for diagnosing anything affecting movement.
It absolutely is. You need to break down this alternating process.
Right. So a full cycle is from when one foot hits the ground until that same foot hits the ground again. And it's basically split into two main phases.
Correct. You've got the swing phase. That's when the foot's off the ground, swinging forward. That takes up about 40% of the cycle time. Then there's the stance phase, foot on the ground, bearing weight. That's the other 60%. And importantly, within that, there are two short periods of double support, where both feet are actually on the ground at the same time, about 10% each.
And the stance phase is where the real work happens, starting with heel strike, initial contact, and ending with push-off or toe-off. Where are we using the most energy during walking? It feels pretty effortless most of the time.
Yeah, it seems smooth, but most of the energy gets focused into two key moments. First, right after heel strike, during what's called the loading response. Here, your dorsiflexors, mainly the tibialis anterior muscle in the front of your shin, have to contract eccentrically.
Eccentrically meaning they're active but lengthening.
Exactly. They're controlling the descent of the forefoot, slowly lowering it to the ground. Without that control, your foot would just slap down hard.
It's the foot drop, right? That muscle's weak.
That's the classic sign, yeah. The second big energy peak is the push-off. This needs a really powerful concentric contraction muscle shortening of the plantar flexors. That's your calf muscles, the triceps surae group, gastrocnemius and soleus. That's what lifts your body and propels you forward into the next step.
Makes total sense for moving forward. But what about staying upright? Let's talk stability, especially the hip muscles. The abductors, gluteus medius and minimus, seem key here.
Oh, they are absolutely critical, maybe the unsung heroes of walking. Their main job kicks in during the single support phase of stance. That's when only one foot is on the ground.
Okay.
As soon as you lift one foot, the gluteus medius and minimus on the standing leg have to contract hard. Why? To keep your pelvis level. They stop the pelvis from tilting down on the side where the foot is swinging free.
So if my left foot is swinging forward, my right glute abductors are firing like mad to hold my pelvis straight.
Precisely. And if they don't or can't, well, that's the basis of a famous clinical test.
The Trendelenburg test.
Exactly. If you ask someone to stand on one leg and the pelvis on the unsupported side drops or sags down, that's a positive Trendelenburg sign. It tells you the abductors on the standing side are weak or not working properly. Could be nerve damage, like to the superior gluteal nerve, or maybe hip joint problems like that coxavara we talked about.
Wow. Okay, so that test directly links anatomy to function and potential pathology. Very cool. What about the hamstrings? We usually think of them as, powerful hip extensors for running or jumping. What are they doing during just normal walking?
It's interesting. In normal level walking, their main role isn't really about propulsion. It's more about control, specifically deceleration. They become most active towards the end of the swing phase, the terminal swing.
As the leg is swinging forward just before landing.
Right. As your leg swings through and your knee starts to straighten out, the hamstrings contract eccentrically again. They're putting the brakes on hip flexion and knee extension, slowing things down so your foot lands correctly for the next heel strike.
So controlling momentum, not generating it. Another eccentric action. Now, what if someone loses that powerful plantar flexion? Say their calf muscles are paralyzed, maybe from a tibial nerve injury. Can they still walk?
They can, but the gait changes significantly. If the triceps surae can't provide that powerful push-off from the forefoot, propulsion has to come from elsewhere, mainly the gluteus maximus and hamstrings acting at the hip. but the ankle itself will just be passively dorsiflexed during push-off.
So how do they compensate?
Often, to get some forward momentum from the foot, they'll learn to rotate their foot outwards and sort of roll off the midfoot, rather than driving powerfully off the toes. It really shows you how integrated all these muscle actions are for efficient walking. Loss of one component forces compensations elsewhere.
Right. Let's shift gears now to the neurovasculature and those fascial compartments. Starting with the big artery, the femoral artery. Its location seems really important clinically.
It's probably the most accessible major artery in the body, which is incredibly useful. You can easily feel the femoral pulse about halfway between the ACEs, that bony point in the front of your hip, and the pubic symphysis, right in the groin crease. Or maybe more accurately, just below the midpoint of the inguinal ligament.
And why is finding that pulse so important beyond just checking circulation?
Well, that exact spot is the standard place to access the artery for major procedures, like left heart catheterization, for instance. Clinicians insert a catheter there, can compress the artery against the underlying bone, the superior pubic ramus, to control bleeding, and then guide that catheter all the way up the aorta to the heart, knowing that surface anatomy is absolutely critical for safe vascular access.
Okay. And what if, for some reason, blood flow through the main femoral artery is blocked or needs to be tied off? Is the leg just done for?
Not necessarily, thanks to something called the cruciate anastomosis. It's basically a network of backup arteries around the hip joint.
Yeah.
You've got branches from the circumflex femoral arteries connecting with branches from the inferior gluteal artery and the perforating arteries from the deep femoral.
So a natural bypass.
Sort of, yeah. It provides collateral circulation. If the main femoral artery is blocked high up, this network can potentially provide enough blood flow to keep the leg viable. Although the source material does caution that ligating the femoral artery proximally is still pretty risky. Even with this anastomosis, it might not always be sufficient.
Good to know. Now, moving down the leg, let's talk about the fascial compartments. These seem like a double-edged sword, organizing muscles but also creating risks.
That's a good way to put it. The leg is divided into distinct compartments by really tough, unyielding structures. The tibia, the fibula, the membrane between them, and these thick fascial walls or septa. The muscles live inside these tight boxes. And the anterior compartment, the one on the front of the shin, is particularly prone to problems.
And the main problem is compartment syndrome, right? What makes that anterior compartment so vulnerable, and what do you do about it?
Exactly, compartment syndrome. Because the boundaries are so rigid, if anything causes swelling inside that anterior compartment, like a fracture, a bad bruise, even just really intense exercise, sometimes the pressure inside skyrockets. There's nowhere for the swelling to go.
And that high pressure is dangerous.
Extremely. It compresses the blood vessels and nerves running through the compartment. If the pressure gets too high for too long, the muscles start to die from lack of oxygen, ischemia, and the nerve can be permanently damaged.
Thus, it's an emergency.
A surgical emergency, yes. If you suspect acute compartment syndrome, the treatment is immediate fasciotomy. You surgically cut open the fascia, that tough outer layer, to release the pressure and restore blood flow. It can save the limb and prevent permanent disability. It's all dictated by that restrictive fascial anatomy.
Wow. Okay, one more condition before we leave the limb, the psoas abscess. This sounds like it originates higher up.
It does. The psoas major muscle is a big hip flexor, but it starts way up in the abdomen, along the lumbar spine. It has its own fascial sheath. Now, if you get an infection nearby, maybe tuberculosis in the vertebrae, which used to be common, or sometimes severe Crohn's disease affecting the bowel nearby pus, can collect within or around the psoas muscle.
And then where does it go?
It can track downwards, following the path of least resistance, which is along that psoas fascial sheath, right down into the groin and upper thigh.
And what's the clinical significance? Why is this tricky?
It creates a real diagnostic headache. The abscess can show up as a swelling in the groin, which might look like a swollen lymph node, or even a femoral hernia. Plus, the inflammation can irritate nerves that run near the psoas, like the femoral nerve, causing pain referred to the hip, the thigh, or even the knee.
So again, pain in one place, problem somewhere else.
Exactly. You have to know about that potential pathway of infection along the psoas fascia to consider an abscess originating higher up when someone presents with groin swelling or unexplained hip or thigh pain.
Okay, got it. Let's completely change gears now and move up to the head. The cranium. It's clearly designed for protection. How do the sources break down its main parts?
We usually divide the skull into two main functional parts. There's the neurocranium, that's the part that actually encloses the brain. It makes up most of the volume. And then there's the viscerocranium, that's the facial skeleton, which is smaller, especially in infants.
And the skull isn't uniformly thick, right? It has stronger areas.
Correct. It has these thickened areas called cranial buttresses. Think of them like reinforcing struts or beams. You find them in places like along the midline, the zygomatic arches, cheekbones, and around the orbits. Their job is to transmit impact forces away from the weaker areas and towards these stronger zones, helping to dissipate the energy and protect the brain.
The overall curved shape helps too,
Yeah,
presumably.
absolutely. The convex shape is inherently strong and helps distribute forces. But, a hard enough blow can still cause fractures. The most common type are simple linear fractures, just cracks in the bone. But the more dangerous ones are depressed fractures.
Where the bone gets pushed inwards.
Yes. If a fragment gets pushed in, it can directly bruise or tear the underlying brain tissue or the meninges, the protective layers around the brain. That's obviously much more serious.
Okay, moving just outside the bone. Let's talk about the scalp. 5 layers SCALP. But which layers are most important clinically, especially regarding injuries?
Layers 2 and 4 are the ones you really need to remember. Layer 2 is the dense connective tissue. It's packed with blood vessels. And crucially, the walls of these arteries are firmly stuck to that dense tissue.
Meaning they can't clamp down properly when cut?
Exactly. They can't constrict effectively, which is why even relatively small scalp cuts can bleed so dramatically. It's not necessarily huge arteries, just lots of smaller ones that won't spasm shut.
Okay, that explains the bleeding. What about layer 4?
Layer 4 is the loose connective tissue. It's sometimes called the danger area of the scalp.
Why danger area? Sounds ominous.
Because it's, well, loose. It provides a really easy plane for things to spread, like pus from an infection or blood from a hematoma. And the really dangerous part is that this layer contains emissary veins.
What are those?
They're small veins that pass directly from the scalp through holes in the skull bone and connect to the large venous sinuses inside the cranium, the ones that drain the brain. These emissary veins have no valves.
Uh-oh. So infection can track inwards.
Precisely. An infection in that loose connective tissue layer of the scalp can potentially travel straight through an emissary vein into the cranial cavity, leading to serious complications like meningitis or even a brain abscess. That's why scalp infections need to be taken seriously.
Got it. And one last thing on scalp wounds. Why do some gape open widely while others don't?
It depends on which layer is cut and what direction. If the cut is superficial, only through the skin and dense connective tissue, the underlying epicranial aponeurosis, that tough sheet in layer 3, holds the edges together so it doesn't gape much.
But if the cut goes deeper?
If the cut goes through the aponeurosis and it's oriented in the coronal plane, side to side across your head, then the wound will gape wide open. That's because the frontalis muscle belly at the front and the occipitalis muscle belly at the back are constantly pulling that aponeurosis in opposite directions. Cut it across that line of tension, and the edges spring apart.
Right. Makes sense. Now, thinking about development, the infant skull is quite different, isn't it? Especially the proportions and those soft spots.
Yeah, very different. The neurocranium, the brain case, is proportionally much larger compared to the face. The face looks small because the jawbones, maxilla and mandible, the paranasal sinuses, and the teeth are all still pretty underdeveloped. And then you have the fontanelles.
The soft spots.
Right. These are areas where the skull bones haven't fused yet, covered by tough, fibrous membranes. They allow the skull to deform a bit during birth, which is helpful, and also allow for the rapid brain growth that happens after birth.
And they're useful for doctors examining a baby.
Oh, absolutely.
Yeah.
By gently feeling the fontanelles, especially the large anterior one on top, you can get a sense of what's going on inside. Is it bulging? That might suggest increased intracranial pressure. Is it sunken? That could indicate dehydration. It's a quick, non-invasive assessment tool.
Important clinical window, and one anatomical variation to keep in mind.
Yeah, the metopic suture. This is the suture line that runs down the middle of the frontal bone. Usually it fuses completely in early childhood, but in about 8% of people it persists into adulthood. The key thing is not to mistake this normal variation for a skull fracture on an X-ray or CT scan.
Good tip. Okay, let's dive inside the cranium now and focus on the cranial nerves, starting with the first two, olfactory and optic, which are a bit unusual.
They are CNI, the olfactory nerve for smell. Its tiny nerve fibers pass up from the nasal cavity through little holes in the cribriform plate of the ethmoid cone to reach the olfactory bulb, which sits right on top.
And that location makes it vulnerable.
Very much so. A significant head injury, especially one involving rapid acceleration or deceleration, can shear those delicate filaments as they pass through the bone. The result, anosmia, the loss of sense of smell, sometimes temporary, sometimes permanent.
And CN2, the optic nerve for vision. You mentioned it's not really a peripheral nerve.
That's a really key concept. The optic nerve is actually an extension of the brain itself. Technically, it's a CNS tract.
Yeah.
And this has a massive clinical implication regarding its structure. Its myelin sheath, the insulating layer around the nerve fibers, isn't made by Schwann cells like peripheral nerves are. It's made by oligodendrocytes.
Like the rest of the central nervous system.
Exactly. And that means the optic nerve is vulnerable to diseases that specifically attack CNS myelin. The classic example is multiple sclerosis, MS. Inflammation of the optic nerve, called optic neuritis, is often one of the very first symptoms of MS.
Wow, so that cellular detail, oligodendrocytes versus Schwann cells, directly links the optic nerve to CNS pathology. Okay, let's jump to the big sensory nerve of the face, CNV, the trigeminal nerve. 3 main divisions, V1, V2, V3. Crucial for nerve blocks, right?
Absolutely. If you need to numb up parts of the face for, say, stitching a wound or doing dental work, you target specific branches of the trigeminal. For instance, an infraorbital nerve block targets a branch of V2 as it comes out of the infraorbital foramen, just below the eye. That numbs the upper lip, side of the nose, lower eyelid, and maybe the upper incisor teeth.
What are the risks with that block? Seems close to the eye.
2 main things. First, you always need to aspirate before injecting pullback on the syringe to make sure you're not inside the infraorbital artery or vein that runs with the nerve. Injecting into a vessel is bad news. Second, if you go too deep or angle incorrectly, the anesthetic could potentially affect some of the extraocular muscles that move the eye, causing temporary double vision.
Okay, caution needed. And what about numbing the lower jaw, like for dental work?
For that, you typically do an inferior alveolar nerve block. This targets the main sensory nerve to the lower teeth, a branch of V3, just before it enters the mandibular foramen on the inner side of the jawbone. Done correctly, it numbs all the mandibular teeth on that side, right up to the midline, plus the lower lip and chin via the mental nerve branch.
Any common complications there?
The main one is inadvertently injecting the anesthetic into the medial pterygoid muscle, which lies very close to the injection site. If that happens, it can cause muscle spasm or trismus, making it difficult for the patient to open their mouth fully for a while.
Right. Okay, let's switch to some key motor nerves. CNN7, the facial nerve. The source calls it the most frequently paralyzed motor nerve.
It is, unfortunately. It's complex because it carries motor fibers to all the muscles of facial expression, but also parasympathetic fibers to glands, and taste fibers from the front of the tongue. Where the injury occurs along its long, winding path determines the pattern of symptoms.
So an injury high up near the brainstem would cause more problems.
Yes. An injury inside the skull or within the facial canal in the temporal bone could knock out everything. Paralysis of the entire side of the face, maybe loss of taste on the anterior 2/3 of the tongue, altered tearing or salivation. An injury outside the skull, like in Bell's palsy, which affects the nerve after it exits the stylomastoid foramen, might predominantly cause just the facial muscle paralysis.
Got it. What about the pair involved in swallowing and gagging, CNIX, and X, glossopharyngeal and vagus?
They work together, especially the gag reflex. CNIX, the glossopharyngeal, is mainly the sensory limb that detects the stimulus, the touch, on the back of the tongue or pharynx. CNX, the vagus, is the motor limb that triggers the muscular contraction, the gag itself.
And there's a clinical sign associated with vagus nerve damage.
Yes, related to the palate. The vagus nerve supplies most of the muscles of the soft palate. If CNX is damaged on one side, those muscles are weak or paralyzed. So when you ask the patient, say, ah, and look at their throat.
The uvula deviates.
It deviates away from the injured side. The healthy muscles on the normal side pull the palate upwards and sideways, unopposed. It looks like a curtain being drawn to one side, sometimes called the curtain sign. It points towards the healthy side.
Clear indicator. Okay, moving down into the neck slightly. CNSCM, the spinal accessory nerve, what's its job?
CNS is purely somatic motor. It supplies just 2 major muscles, the sternocleidomastoid, SCM, in the front side of the neck, and the trapezius muscle on the back and shoulder.
And it's vulnerable.
Extremely vulnerable, particularly where it runs somewhat superficially in the posterior triangle of the neck. Surgeries in that area, like lymph node biopsies, can easily damage it. The result, paralysis of the trapezius leading to shoulder droop and difficulty raising the arm above horizontal, and paralysis of the SCM causing weakness and turning the head against resistance towards the opposite side.
Okay, and finally the tongue mover, CN12, the hypoglossal nerve.
This one is motor to almost all the muscles of the tongue, both intrinsic, changing its shape, and extrinsic, moving it around. The only exception is the palatoglossus muscle, which gets vagus nerve supply.
And damage to Sienna-12 also gives a clear clinical sign.
Yes, a very clear one. Ask a patient with a hypoglossal nerve lesion to stick their tongue straight out, because the muscles on the healthy side are working fine and the muscles on the paralyzed side are not. The tongue will deviate towards the paralyzed side. The genioglossus muscle on the good side pushes its half forward, but the weak side lags behind.
So tongue points to the lesion. That's easy to remember. And there's a safety issue with Sienna-12 during anesthesia.
Absolutely critical point. The genioglossus muscle is the main muscle that pulls the tongue forward out of the airway. When a patient is under deep general anesthesia, all muscles relax, including the genioglossus. If the tongue falls backward, it can completely block the pharynx, obstructing the airway. That's why maintaining a clear airway is paramount during anesthesia.
Very important. Okay, let's talk briefly about the protective layers again, the durameter and those venous sinuses, and their own potential problems.
Right. The durameter itself, especially near the big venous sinuses and where the meningeal arteries run, is quite sensitive to pain. That's the basis for certain types of headaches, like the one people sometimes get after a lumbar puncture, a spinal tap.
How does that work? Removing spinal fluid causes a headache.
Yeah. When you remove cerebrospinal fluid, CSF, from the lumbar sac, you slightly reduce the volume and pressure of CSF within the entire system, including around the brain. This can cause the brain to sag slightly within the skull, pulling on the pain-sensitive dura, especially where it's anchored. Lying flat often relieves it because it reduces the sagging effect.
Makes sense. And the venous sinuses themselves, you mentioned they connect to veins outside the skull.
Yes, and this is a crucial point about potential spread of infection or other problems. The dural venous sinuses, particularly the ones at the base of the skull, like the basilar and occipital sinuses, have connections with the venous plexuses around the vertebrae, the internal vertebral venous plexuses. And importantly, all these veins are valveless.
Meaning blood can flow either way.
Exactly. So if pressure increases suddenly in your abdomen or chest, like during forceful coughing, straining, or even having a bowel movement, blood can be forced upwards from the body, through the vertebral plexuses, and directly into the dural venous sinuses inside your head.
And that could carry.
It could carry venous blood, obviously, but also potentially pus from an infection, bacteria, or even tumor cells from the abdomen or thorax, seeding them directly into the cranial cavity or brain. It's a potential pathway for metastatic spread or intracranial infection.
That's quite a vulnerable connection, and we can't talk about head injuries without mentioning the classic epidural or extradural hematoma.
Right. This is usually caused by tearing an artery, most commonly a branch of the middle meningeal artery, often due to a skull fracture crossing the artery's path, frequently near the baterion on the side of the head. Because it's arterial bleeding, it accumulates relatively quickly between the durameter and the skull bone.
And the clinical course is characteristic.
It's the classic pattern you have to know. The person might have a brief loss of consciousness from the initial blow, then they seem to recover. They have a lucid interval where they feel okay and can talk. But meanwhile, the hematoma is growing, compressing the brain. As the pressure builds, they become drowsy, confused, and can rapidly progress to coma and death if not treated surgically to evacuate the clot. That lucid interval is deceptive and dangerous.
A true neurosurgical emergency then?
Absolutely.
Okay, we've covered a huge amount of ground from the pelvis all the way up to the cranial nerves. Let's try to pull together a few final clinical takeaways, starting back down at the lower limb with common injuries.
Yeah, thinking about fractures, remember the tibial shaft often breaks at its narrowest part, the junction of the middle and lower thirds. It's biomechanically weaker there. And the distal fibula, that outside ankle bone, commonly fractures about 2 to 6 centimeters above the tip of the lateral malleolus, often happening along with severe ankle ligament injuries.
Speaking of which, what's the most commonly injured ligament in the entire body?
That lovely title goes to the lateral ligament complex of the ankle, and specifically the anterior talofibular ligament, or ATFL. It's the one that almost always gets torn or stretched when you roll your ankle inwards, that inversion injury, especially when your foot is pointed down slightly, plantar flex, and bearing weight.
And that's because the lateral side is less stable?
Fundamentally, yes.
Yeah.
Remember, the lateral malleolus sits lower and more posterior. That bony structure provides little resistance to inversion compared to the resistance against eversion, rolling outwards, provided by the medial malleolus. So we're just built to sprain our ankles laterally more easily.
Okay, good summary point. Now, jumping back up to the face one last time, orbital trauma.
Right. A direct blow to the eye area often causes bruising and swelling in the loose tissue around the orbit, the classic black eye. But the force can also fracture the bones of the orbit itself.
Especially the thin walls, the floor, or the medial wall.
Exactly. Those are the weakest points. Even if the strong bony rim around the orbit stays intact, the pressure from the blow can fracture the thin orbital floor, roof of the maxillary sinus, or the medial wall next to the ethmoid air cells. This is called a blowout fracture.
And the risk there is involving the sinuses.
Yes. You can get orbital contents, like fat or even eye muscles, herniating down into the maxillary sinus, or air from the ethmoid sinuses escaping into the orbit, orbital emphysema. There's also a risk of infection tracking between the orbit and the sinuses.
Okay. So wrapping all this diverse material together, the biomechanics, the fascia, the nerves, the vessels, what's the real bottom line for someone learning this clinically oriented anatomy?
I think the bottom line is seeing how interconnected it all is, and how seemingly basic anatomical facts have direct clinical consequences you might not immediately think of. Knowing about coxa isn't just abstract geometry, it explains why a child might limp and have knee pain.
Right, and understanding the Trendelenburg test isn't just memorizing a name. It's a quick functional assessment of the hip abductors and their nerve supply, telling you about stability.
Exactly. And up in the head, knowing the difference between an epidural hematoma, arterial, rapid, and a subdural hematoma, usually venous, slower, comes down to knowing the anatomy of the meningeal vessels and sinuses. Knowing that the optic nerve has CNS myelin explains its link to MSD.
So the bones give the structure, but it's really the fascia, the nerves, and the vessels that define the pathways for problems, whether it's compartment syndrome, infection spread like that so has abscess, or through emissary veins, or nerve injury patterns.
Precisely. It's about using that detailed anatomical map to understand function, predict problems, plan interventions like nerve blocks or vascular access, and interpret clinical signs. That's the clinical orientation.
Excellent summary. So we've concluded this particular deep dive, weaving together insights from the lower limbs foundation and the cranium's protective structure. We've really tried to highlight the clinical context for movement, trauma, and how the nervous system functions and where it's vulnerable.
Yeah, from using the fibula as a spare part in surgery to knowing exactly where to find the femoral artery to recognizing those subtle but critical signs of cranial nerve damage. It all comes back to having that solid anatomical knowledge base.
So next time, we promise, we will actually get to the original target chapter. We'll be diving into the viscera of the neck, looking at the endocrine layer, the thyroid and parathyroid glands, the respiratory layer with the larynx and trachea, and the alimentary layer, the pharynx and esophagus. We'll see how all these vital systems are packed together in that complex space.
Looking forward to it. Thanks for listening to Bookfulness.